The title of my talk is Making EHRs Smart. I'm a little nervous because when I told Dean this, he said that I should actually call it No EHRs Left Behind. But got worried that he was making fun of one of the signature education initiatives of my favorite president, so I didn't appreciate that. So that's really what my talk is about, and that's kind of the story of what I want to try to do today. So let me start by showing you a picture. This is something that we're very proud of. This is the longitudinal medical record. This is our electronic health record at my hospital at the Brigham. It's a ONC APCB certified EHR that we've developed, and I get nostalgic now when I show this picture because, as many of you guys may know, we are buying Epic at the place that I work at, and so it's a big change for us, and we have a very long history sort of making our own stuff. I'll tell you that as proud as we are of this system and of our related systems, they really are mostly just filing cabinets for patient data. And so if you take a look at this, this is a pretty typical layout for an electronic health record, but we have a problem list, a set of medications, some procedures, the allergies, the notes. These are all sort of discrete, sets of data, and there's not a lot of relationship between them on the back end. Somehow somebody mentioned earlier this idea that you could look at a data schema and say, wow, this maps exactly to this particular database layout, and this is really, I think, sort of an example of. So the one sort of exception, I think, to this filing cabinet metaphor is the reminders. So like many people, we have developed rule-based sort of reminders and alerts that we've been kind of talking about. And many of these have worked. I guess one of the reasons that we're proud of this is we have a lot of randomized trials that show as we put these in, the rates of people doing the things that we were hoping that they would do sort of increase. And one of our goals for having the EHR is to improve safety and to improve quality. But our users are often sort of frustrated that this really is just sort of a kind of filing cabinet metaphor. And I'll show you one example of this. So this is a screenshot of a test patient, but I sort of got most of the data from one of our real patients. And what people sort of start to see when they look at this is that there's a lot of things that are sort of out of whack. So if you look, it's clear this patient has diabetes when you look at their A1C, when you look at their medications, but it didn't make it onto the problem list. Similarly, you might look in the notes and realize that we've given the patient something like aspirin that's a medication that they're taking, but that didn't make it onto the medication list. And so we took a look at this, and what we found was that the sort of completeness rate at which we were documenting problems was lower than we intended for it to be. So using the diabetes example, about 63% of our patients with diabetes at our hospital have diabetes on the problem list, which is not to say that we haven't recognized the diabetes in a third of the patients. Usually if we look at their records, you see that we're treating the diabetes, we talk about it in their notes, but we didn't ever quite get it onto the problem list. And at our place, and I think at probably many of your places, we use the problem list to drive clinical decision support, we use it to sort of find patients for research studies, we use it to do quality measurement. And so, these patients are missing out on a lot if they're in sort of third of our diabetics that appear to have diabetes, almost certainly do, but don't have it on their problem list. And then, another factor, of course, is that, ONC is now sort of measuring this, right? 80% of our patients have to have something on their problem list for us to get our meaningful use money, which is always sort of a funny bar, right? It's not that 80% have to have a complete or accurate problem list, that anything has to be true, just that the problem list can't be blank more than a fifth of the time, which is a bar that we weren't meeting at the beginning, but we're sort of now making progress towards meeting. And so, yes? Exactly, yeah. And a lot of those are because they're inpatients, and we make sort of less use of our problem list in the inpatient setting than we do in the outpatient setting. Your interpretation of this is exactly right. And chronic kidney disease is similar. When we look at patients who, based on the KDOQI sort of definitions of chronic kidney disease, have one of the stages of chronic kidney disease, the sort of rate of documentation is less than 10%. And so we've compared this at many other hospitals, and our numbers are pretty typical. We've done this, I think, now at like 12 or 13 hospitals for diabetes, and the numbers have ranged from 50% up to above 90%, although the 90% was in another country that sort of has a very sort of aggressive pay-for-performance program, so you really only get paid for your patient if you have the problem list right. So this is a problem that seems to happen everywhere. And our sense is that a lot of that is because the EHR lacks the sort of sense that we have as physicians or other users of the system about what we need to be doing. And so we have tried through the course of this project to make things a little bit different or a little bit better. And so, this is a system that we've now developed that tries to kind of cull information from various parts of the record about, say, diabetes, sort of show just the diabetes-related medications and lab results and some suggestions about diabetes. This is one for the patient's cholesterol. We have another version that sort of shows a spark line to track the A1C. And when we've tested these, people have liked them. I mean, so we've done a variety of laboratory tests where we sort of bring people in and have them use these things. They seem to be faster. They seem to make fewer errors. They seem to have a more complete picture of the patient. And so this was sort of, when you read the proposal, I know that Muhammad talked about the sort of original aims of the proposal. We really talked a lot about doing this. And after we built it, what we realized was the hardest part was getting the knowledge you need to do this. It turns out that you need a pretty big sort of clinical knowledge base to build these summaries. And so we made them for 7 or 8 different conditions at the Brigham, but we realized that there's hundreds of things that we treat, and we really wanted to be as complete as we could. So that sort of changed our focus from sort of the user interface to the knowledge bases that we would need. This was another sort of sample of a user interface that we looked at. And what we realized was that we couldn't engineer the knowledge bases as fast as we needed them. So we turned to data mining. And so these are some of the results of an association rule mining study that we did. So I don't know, I guess everyone in some way probably has encountered association rule mining if you've ever bought a book on Amazon. You know how sort of you buy one book and it says people who enjoyed this book also enjoyed this book. There's sort of a similar analog here. People who enjoyed, prescribing, haloperidol enjoyed adding schizophrenia to the problem list. And so so we did this mining at the Brigham and had pretty good results. We repeated it at the University of Texas, and we're able to build up a pretty large knowledge base, at least for some common conditions, where we had enough of a critical mass of data that we were able to do this. And so we've written papers about this, and the knowledge base is available publicly. But what we realized was that there were some gaps in the knowledge base, especially for medications that are used for a lot of different things. Because somehow if a medication has many indications, none of them might have a strong enough signal, even though really several of them are relevant. And so we looked at other ways that we could build this knowledge base. This is the Allscripts system that's in use at the University of Texas. And one of the things that they make people do when they sort of add a medication is link it to a problem that's on the patient's problem list, or add another problem to the patient's problem list. And what we discovered was that a lot of the time, actually probably close to half the time, people just link everything to the first problem on the problem list because that's the easiest thing to do. And so we first started by trying to mine these and said, well, this will be a great knowledge base that will sort of tell us what medications relate to what problems. So we realized quickly that we couldn't just sort of count on the fact that a link had been asserted by the physician to assume that it was accurate. And so we started developing a number of these metrics where we looked at how frequently a link was shared with other patients that had the same medication, what percentage of patients with both that medication and problem had a linkage between them. And that improved our results a lot. But what we sort of discovered was that the results were not uniform by physician. So there were many physicians that took this very seriously. They always linked the medication to the correct problem, or almost always did that. And then there were some physicians that, close to 100% of the time just linked the medication to the first problem on the problem list. And so we developed some reputation metrics to sort of decide which linkages we could trust and which ones we might not be able to trust. Sort of like eBay has, this is a good person to buy this iPhone charger from. This isn't as good of a person to buy the iPhone charger from. This is sort of a good doctor to trust, and this is not as much of a good doctor to trust, at least for this kind of information. We expanded this to sort of natural language processing with Hua Zhu and his colleague Yangwei Wu. They had done some great work where they sort of mined the text of Wikipedia articles and journal articles and medical textbooks and sort of saw what problems and medications tended to sort of co-occur with each other. And then we used that as a sort of piece of evidence that these two things might be related to each other. And so when we were done, we had all of these different knowledge bases. We had, the association rule one from my place, from the University of Texas. We had this crowdsourcing data. We had this reputation data. We had these textual text mining sort of results. And they were all good, but what we realized was we needed to sort of put them together in some way. So we developed the world's largest Venn diagram. And so Yang Wei was the one who did this. And we kind of looked at how many sort of pairs of things fit together. The hardest part about this, it turns out, is the terminology. So often the same linkage would be in 3 or 4 of the data sets, but if one used SNOMED and one used ICD-9 for the problems, it was our job to sort of put those together and realize that, wow, this diabetes is the same as this diabetes, which is possible in a lot of the cases, but what if one knowledge source says, this is linked with type 2 diabetes, and another one says this is linked just with diabetes. Is that a match or is that not a match? And so we're still sort of puzzling over this sort of ensemble method, but I think we think that this has a lot of promise. And these results of this are certainly available to anybody who's interested in them too. I told you at my place that we had a lot of trouble with the completeness of our problem list. And so we actually use some of these knowledge bases to build a sort of suggestion or alert into our information system. And so when a physician at our hospital writes a note on a patient, we run these rules and we try to sort of guess which problems they have. We have these working for 17 diseases right now. And if we're more than about 95% confident that a patient has a particular problem and it's not on the problem list, then we make the suggestion to the patient. We try to give a little bit of an explanation about why we made that suggestion. And we did a randomized trial. So we followed everyone in the trial for 6 months and looked at their sort of rate of adding problems over that 6-month period. And then we turned this intervention on. And you can see in the intervention group, there was sort of this left turn in the graph. This is always what you want your RCT graph to look like when you're done. But we were pretty proud that we've made this difference. We've since rolled it out at several other hospitals, in my institution, and Partners Healthcare, and we're now prototyping it internationally and in a few other places. So this was a sort of, I think, pretty quick win for this kind of knowledge base. But it really depended on this knowledge base. And like I said, we got 17 conditions down. The graph that I don't have here is looking at the other problems, the other 2,000 problems that we can add to the problem list, and there was absolutely no effect on those. So I always joke that that's sort of like full employment for medical informaticians for a while, is finishing from 17 to 2,000. And the trick is we'll never get all the way to 2,000 using just manual methods. There's no way that we could do it, and there's no way we could maintain it after we had done it. So I think we're going to have to depend more and more on these sort of ensemble methods and data mining methods and more complex ways of finding these associations. And in the end, there was actually about a 3-fold increase, depending on how you controlled for some things, in the rate of adding these problems. So this was a sort of quick win for these kind of knowledge bases, and I think what we're most excited about now that we have these knowledge bases is thinking about other use cases. We've got summarization, we've got problem lists, but I think that this could be used for so many different purposes, and so we're very interested in sort of collaborating with anybody who could benefit from these knowledge bases, and certainly are happy to sort of share them publicly. So thank you, guys.